First of all, the result clearly showed us that ranibizumab had high efficacy versus sham in terms of equity gain, and unequivocally established it as a primary mode of treatment. DRCR protocol I then came around and then showed us clearly that the ranibizumab laser combination was better than a standalone laser or an IVTA laser combination. It also showed us importantly that if you were to combine, that it is better to defer the combination laser rather than to go straight up together as prompt laser. So this equity plot at 2 years from the protocol I showed us clearly that ranibizumab deferred was better than ranibizumab prompt laser, both of which was significantly better than just doing only a laser or combining that laser with IVTA. So basically deferring laser is not a bad idea and has equity advantages. Pharmacotherapy definitely scored over laser both in the immediate as well as in the late period. And this advantage in equity was also seen not just at 2 years but also at 3 years and at 5 years. So there definitely there's something to be said for that. And this advantage was also seen in terms of the macular drying or change in retinal thickness, where again deferring the laser was better than doing it prompt. So if you have to do both, you please do defer. Then, very importantly, early intense treatment reduces the treatment burden later. Now, chronic DME is a chronic disease. It's going to be there, this patient is going to be there with you for some time. Very often, some of my junior colleagues, fellows, they think when they see a patient, they're a little hesitant to, treat a little aggressively. And so were we also. But studies have shown us, and this clearly shows us, graph shows us that in the first year, when they treated with 8 and 9 injections based on definitive criteria, the subsequent need for treatment dramatically reduced, as you can see here. In fact, up to 43% of patients required no ranibizumab treatment in year 3. So it's important to treat early and aggressively. Higher safety issues were definitely noted for IVTA in terms of elevated intraocular pressure glaucoma or in terms of cataract genesis, where more than half the patients needed cataract surgery in 2 years. Now, the rise and ride showed us one very important thing, that in untreated eyes, patients who were not or treatment naive, it's still never too late for anti-VEGF treatment. Now, this is another thing which comes up with the junior consultants, fellows, that if you feel an eye has not been treated for a long time, they feel that they may not benefit at all from treatment. That's totally the opposite case. So as this graph shows us very clearly from rise and ride, that the lower graph, the one at the bottom, the white line, which was not treated, these were a bunch of patients. For 2 years, they were not treated. Okay, and then as soon as they were open to Lucentis treatment, you see that almost dramatically it starts shooting up. And so much, and this is more even dramatic with the macular edema. You see for 2 years, when they were not treated, that macula remained thick. And the moment it was open to Lucentis treatment, you see how dramatically they start drying up even after 2 years. So do not desist from injecting your patients. The Restore showed us the same thing with lasered only eyes. Again, it's never too late to treat. Second corollary from the Restore was that adding laser didn't seem to reduce the ranibizumab retreatment rates, which we feel is the USP for laser. So this plot shows us the blue line is the laser only arm, and again you see for 1 year only laser, and you see it's hardly taken off the baseline in terms of equity. But the moment anti-VEGF treatment or ranibizumab was put in, you see it starts snaking up to the effect that at 3 years it catches up with the combination laser arm, so the corollary here is that it doesn't seem to make a difference whether you add anti-VEGF to laser at the start or 1 year later. So again, please do put in anti-VEGF for a patient that has only had laser and is still a little thick. And this graph shows us that all the arms had the same number of retreatments. So it didn't seem to make a difference, but the laser didn't seem to reduce the number of retreatments. Bolt showed us there was high efficacy for bevacizumab for DME. Now, the much talked about DRCR-T trial. Now, the 1 year result showed an advantage for aflibercept over ranibizumab and bevacizumab for poor vision patients, that is less than 20/50 patients. But in the 2 year result, ranibizumab caught up with aflibercept. And the other thing that showed us was unequivocally that bevacizumab reduces macular thickness the least of the 3 drugs. Now, this plot shows us that, as you can see, at the 1 year time point, there was a significant difference between aflibercept and ranibizumab. But ranibizumab over the second year caught up with aflibercept, although it was marginally lesser. That was also seen with the CRT reduction plot. Now coming to the clinical principles. So factors to assess: first, the clinical profile, obviously the fundus picture, the OCT, which is dominant, and also plus minus the FFA, and the best corrected equity. It's also equally important to look at the fellow eye. and then also at the systemic profile, and finally need to rule out the mascaradis. It's also important to look at the dosing history, the kind of drugs that we use, the dosing strategy, and finally an eye on the patient factors, the compliance or financial issues. Yes, please come up. So the clinical profile I've divided into the mitigating factors and the encouraging factors. Mitigating factors being RP degeneration, macular atrophy thinning, subfoveal fibrosis, macular ischemia, poor vision, which for me is about 3/60 or lesser, loss of this ISO's integrity, signs of chronicity, outer retinal tubulations or drill, which we come to recognize recently, disorganization of the retinal inner layers, and the surgical conditions like epiretinal membranes and vitreomacular tractions. If these exist, then one can desist from a very aggressive injecting protocol. But if the encouraging factors like pure clean edema, like this picture here, with or without subretinal fluid and suboptimal vision, which for me is like say 6/18 to 4/60, then one can pursue a more aggressive line of treatments. Some examples of the mitigating factors being macular ischemia, subfoveal fibrosis, macular hard exudates, outer retinal tubulations, macular atrophy, drill, and the surgical conditions like vitreomacular traction and epiretinal membranes. If these are there, you may not progress with a excessive treatment protocol. A good look at the fellow eye is also important. If the fellow eye has good vision, then again one may desist practically from a very aggressive line of treatment. But if the patient is one-eyed, then I would pursue a more aggressive line of treatment. Systemic factors, we know glitazones can cause macular edema. One must rule out nephropathy, hypertension, watch out for anemia, high history of strokes, myocardial infarctions, and allergies. One needs to also importantly rule out mascaradis, like hypertension, which can cause macular edema, MACTEL, which can mimic edema, and X-linked retinoschisis, which causes a skytic edema. Now, management number 1 for refractory DME, which is something which we always face. So I go with monthly anti-VEGF injections till the patient is stable, which means basically equity or OCT unchanged for 2 to 3 visits. And then depending on whether the mitigating factors are there, if the mitigating factors are there, I would go with the wait and extend, or if the encouraging factors are there, the treat and extend. In wait and extend follow-up up to 2 months. If treat and extend, inject and then extend up to 2 months. In both cases, if it's stable, you can extend the follow-up up to 3 months. If it's unstable, you can come back to the aggressive treat and extend formulation. So that is if the dosing is inadequate. If it's adequate, then one can try switch it. If patient is on Avastin and refractory, you can move over to Accentrix or Lucentis and vice versa. So this is an example of case which is refractory to Avastin and benefited with Accentrix, but the reverse was also true. Aflibercept and Zivaflibercept have come in. Aflibercept is expensive, but patients who can afford, you can definitely try, and we've seen very good results. Some of my colleagues in LV Prasad and Cochin have tried Zaltrap or Zivaflibercept, which is basically like, taking it's an off-label indication. We take 1.25 milligrams of inject, and people have shown impressive results. Conbercept is the Aflibercept of the Orient. It's come from China, and they've also reported impressive results. It's still not available in India. Elderly pseudofakes, one may try IVTA. Ozurdex, I think the USP for this is vitrectomized eyes, but I think no other drug really works as well because the pharmacokinetics of the drug is not affected by the lack of the vitreous. Ozurdex has been used successfully for refractory DME. The MEAD study shows that very clearly. 0.7 milligrams significantly improved acuity in patients previously treated with laser and anti-VEGF treatment. Now this issue of pharmaco combination, we had also dabbled with this. Recently, Protocol U DRCR shows us very nicely that adding dexamethasone to ranibizumab offered no real significant advantages in terms of mean acuity improvement as well as mean central foveal thickness reduction. So Hale and Wang's prospective studies also showed that adding IVTA to Avastin also did not show any significant advantage, and this has been our experience also. So basically, then if you have diffuse DME, one can go with combination with IVTA. If lasers are not out of the plan completely, you can use it for non-center involving DME, where if you see those focal microaneurysm, you can still hit it there, and surgical conditions need vitrectomy. And of course, like I said, you need to rule out the mascaradis. Quick look at new laser systems, micropulse subthreshold laser, yellow 577 nanometers now being tried out, duty cycle being 5%. You can do contiguous treatment of the macular edema. There's less RPE damage as seen on autofluorescence and microperimetry, but people are still struggling to get the right protocol. Ochriplasmin has been talked about. It's a 29 kilodalton small recombinant proteins, actively penetrates the epiretinal tissue and induces PVD in some DME cases. Intravitreal fasolil is another drug which has just come up, and there are preliminary reports. It's a Rho-associated protein kinase inhibitor. So finally, the other alternatives are injecting at an increased frequency, 2 to 3 weeks, dose hike, drug cocktail, drug holidays, limited vitrectomy without ILM peeling, and as I mentioned, some of the future directions apart from micropulse lasers, Iluvien, Fasudil, and this new drug called ALG1001 Luminate, which is an integrin adenocorticoid. So this kind of encapsulates how one needs to strike for DME. Thank you.